let me just start by welcoming everyone. We are a few minutes in. So good morning, good afternoon, good evening, colleagues, wherever you're joining us from. On behalf of the NNN Schistosomiasis and soil-transmitted Helminths, this is specific group. It's my pleasure to really welcome you to the 2026 media virtual meeting. My name is Crispin Oaga, the chair of the STH DSG and country director for Evidence Action, Malawi and Kenya. Before we begin, a few housekeeping announcements to help us through this webinar today. The meeting is being recorded, as Anouk has already indicated, and we'll consult with the speakers regarding sharing the recording out. But later on, and the webinar is going to be conducted in English with French translations, interpretation available through interpretation function at the bottom of the screen. So for questions, kindly use the Q&A function and indicate whether, which speaker your question is directed to. We also encourage you to, introduce yourself and connect with fellow participants. So the chat is enabled now, everybody. So feel free to just, share the name, the organization, as well as where you are joining us from. That would be really appreciated. Finally, note taking will not be admitted in the session. And thank you all for helping us create an engaging, productive discussion for the day. And so before, getting into the gist of the day, today's agenda, I will just briefly remind us that why this group exists and why our collaboration continues to be important. The DSG SCH Schisto serves as a platform to accelerate progress towards WHO targets for schistosomiasis and soil-transmitted Helminths, and our role is basically to strengthen coordination among NGO partners, foster learning across programs and countries, and promote sustainable, comprehensive approaches to control and elimination using a best framework. And at its core, our group generally, seeks to foster collaboration among implementing partners, build evidence and help mobilize resources, facilitate knowledge exchange and learning, strengthen relationship between governments, partners, WHO, communities, and donors. And today's meeting is part of that broader effort that we continue to serve. And together with our annual conference later this year, these engagements help us to share progress, identify evidence gaps, discuss innovations that are coming up, strengthen collective action across the SCH Schisto community. And so in setting today, the scene for today, the meeting has three main objectives. Basically, first, we'll hear an important update from WHO on the newly released validation framework for STH as a public health problem. And secondly, we'll be also listening to learn from a Nigerian experience in integrated NTD delivery, an area of growing interest as programs seek greater efficiency and sustainability. We know of the changing landscape and everything that has been happening within the donor landscape. So, a very pertinent question and discussion at this point in time. And I think lastly, just be able to share important governance updates for the disease-specific group, including introduction of our newly elected vice chair, as well as launching our advisory council. So I'm pretty delighted to have all of you and taking time to be with us today. And your participation and engagement, is what really makes this community valuable. So in terms of just introducing the speaker for the day to quickly join into today's discussion, it is my pleasure right now to introduce our first speaker of the day, Dr. Denise. Is a medical doctor and a public health specialist with the WHO, where she works with prevention and control of neglected tropical diseases. She brings extensive experience in supporting countries on schistosomiasis and soil-transmitted Helminths programs across multiple regions, and has been closely involved in shaping WHO guidance in this area. Today, she will present on the WHO manual on validation of elimination of STH as a public health problem, basically covering, the criteria, the indicators, procedures countries will need to follow as they move toward, validation. And this, is particularly important at this point in time where a lot of countries are moving towards elimination. So as we approach elimination thresholds and begin thinking carefully of what comes, next after preventive chemotherapy, I think this is necessarily a very topical issue for the day. Dr. Denise, thanks and welcome for joining us today. Over to you.
Yeah, thank you very much for giving me this opportunity to share with you and all our partners and countries on this manual that has been released by WHO in this last month on validation of soil-transmitted Helminth elimination as a public health program in children. Here we are going to just go through what's the main information that is in this manual. And I will be also sharing the link where you can download the manual. And then we can also have time for questions. So as you know, WHO has a roadmap that we are following with the target for most of the NTD to achieve by 2030. And for soil-transmitted Helminth, the target is to eliminate the soil-transmitted Helminth in children in most of the endemic country, and also to have an efficient program to reach women of reproductive age with dorming at opportunity times. So the threshold that has been put in this roadmap is that country need to reach at least less than 2% prevalence of moderate and heavy intensity infection in all endemic units, and also reaching at least less than 20% for any STH prevalence in all endemic units. That's the basis that we use to develop this manual. So what's validation? Validation is a process of documenting specific criteria defined by WHO to assess the elimination of a disease as a public health program. For soil-transmitted Helminth, achieving elimination does not mean the cessation of the program. The program will have to continue, but in a certain way. So there's also what this means, it's that country needs to have pre-validation and post-validation surveillance to look on any resurgence of STH above the threshold. So all units, all implementation units that were classified as needing preventive chemotherapy should meet all these criteria before initiation of the validation process. So what are the steps for validation? As you know, many countries have been doing the PC implementation for more than 5 years. And so the first criteria is to have done this PC for more than 5 years and to have reached 75%, at least 75% treatment coverage in those implementation units. And then the country will have to show that the result that shows the prevalence of moderate and heavy intensity that is less than 2% and prevalence of any STH less than 20%, but the moderate and heavy intensity need to be less than 2%. So after this impact assessment, country will enter the pre-validation surveillance period, where a country could choose to review the PC, the number of PC rounds based on the prevalence. So whether you can go from 2 rounds to 1 round, or one round to every 2 years, depending on the prevalence of the disease. And then after the 3 years, another impact assessment to show that you have been able to sustain those thresholds, moderate heavy intensity less than 2% and prevalence less than 20%. After that, then country will be able to work on the dossier and submit their dossier to WHO for validation of STH as a public health program. If you haven't reached those thresholds, then you will have to continue as previous doing the number of rounds of PC
Comme on
that
l'a
was doing.
fait auparavant.
So these are the criteria that I was saying. The prevalence of any STH need to be less than 20% in any implementation unit. So that, which means that you have to get to that prevalence for all your implementation units. So before submitting the dossier. So here I'm saying for the first row, if you have only the prevalence that is higher than 20%, you should not even think about validation. You should continue to do the PC. Even if the prevalence of STH is less than 20%, but the MHI is still more than 2%, then even at that time, you should continue to do the PC as WHO guideline stated. The validation process should not be initiated. The process should only be initiated if you have the two criteria met. The prevalence of any STH species is less than 20% in all implementation units, and then the MHI is less than 2% in all implementation units. Then there you can enter the pre-validation process, the validation phase after 3 years. Or if you can show you can be able to sustain those thresholds, then you can start the process to the validation. What are the steps to the validation? You have to prepare a dossier. As many of you, there are countries that have already done this process for other NTDs, for LF, for trachoma. It's not much different. You have to prepare the dossier. The dossier will need to be submitted to WHO country office, WHO representative in the country, and then it will be sent to the region that will convene an ad hoc group to review the dossier. It's not reviewed by HU, but it's reviewed by the region, and to put in place a ad hoc group with STH experts to review if the documentation is sufficient to validate the country as eliminated STH. Then, if the group acknowledge the claim of elimination, or there are two ways. So they acknowledge the elimination or they postpone the decision based on the data that country has submitted. If it's validated, then country will get an acknowledgement from the WHO director. Or if it's not, the data is not sufficient, then the dossier will be sent back to the country with comments on how they can improve the dossier. So what's requirements to put in the dossier? Most of the thing is the data on program implementation, program overview, the preventive chemotherapy coverage data for school-age children, preschool-age children, at least more 10 years, because we know that most of the country have been doing this for more than 10 years. Then the epidemiological evidence, baseline impact data, the intervention that has been put in place for STH elimination as a public health program, and then also the supplementary intervention that will play a key role for decision maker, for people that will review the dossier. They need to see if the wash data, if the environmental improvement, the behavior change activities that has been put in place to be able to evaluate if this can be the threshold can be sustained. Also, to the data on the warming of women of reproductive age, this needs to be put in the dossier, and mostly important, the post-validation plan. Because what we are saying that if you get validated doesn't mean that the PC will stop. Perhaps some of the area you will do once every 2 years, or to be even based PC, but you should show what are the post-validation plan, especially the surveillance plan, because we know that this position will be reversible if nothing is done. And also that's why we emphasize on the surveillance. If there is no surveillance, post-validation surveillance plan, I don't think that country will get the validation. So we need to see if country is planned to continue to do surveillance and to make sure that they will be able to detect if there's any rebound of the infection in the country. So that's the mainly thing that is we have in the dossier. And this, when you have put all this together, and what I want to say also is that you don't need to wait until you have reached all the threshold to start putting everything together. I know country have the baseline data, they have the program intervention, so you can start putting together if you are thinking that in 2 or 3 years you will be doing your dossier. Yeah, we need to start now thinking about the dossier. So that's all. Thank you for your attention, and I'm here for any question that you would like to ask on this. But there's a place where there is a link. Yeah, this is the link for the dossier. You can get it. We are trying to put it in French as well. So any support also we will be happy to have for this, to translate in French for country. All country can translate it for themselves. Thank you.
Thank you, Denise. Thank you for that insightful presentation. Very clear in terms of moving forward. One of the aspects today, clarity around validation and actually what it needs to be done, and how we then need to move forward. I think a lot of countries, as I'm suspecting, are reflecting not only on where the technical criteria is going to, or where it's going to fall, but also to practically what it means for programs in countries and, ministries that are approaching these particular thresholds. I know, as you've indicated, a lot of countries are already, had very active programs. And so most of them are moving towards the tail end. So as participants are, formulating their questions, possibly, I know in the chat you can, as countries represented today, feel free to begin thinking and share with us, how you think this is going to be and what uncertainties you might be facing. We are going to have approximately 20 minutes for Dr. Denise to respond to questions that might be coming in. So please kindly feel free to submit the questions through the Q&A function directed to Dr. Denise. I know Anok will help me with direct these questions and picking these questions so that she can respond to it. So this is open for all the questions to start trickling in. Anouk, if there are any questions that are already on the chat, you could be able to share those with Dr. Denise, and she can start responding to that. Thank you. Over to you, Anouk.
We don't have yet in the Q&A or in the chat. However, 2 people have raised their hands. So if you wish, I can give them permission to talk. It yes, may or may not work. Shall I? So I think we first have Xavier Badia, who's asked to speak. So Xavier, I'm going to attempt to give you permission to talk. Hold on. Yes, we can hear you.
Okay, thank you. Thank you so much for the presentation. I have some questions regarding the timeline. So my first question would be, sometimes a country have different, let's say, timelines. So different regions, different implementation units are at different stages in the MDA rounds. So my first question would be, if some regions or implementation units have 5 rounds, but other parts of the country have 0 rounds, can they do already the first impact assessment in the implementation units that have achieved the 5 rounds? Or they have to wait for the others? And then what happens if they pass the first impact assessment? Do they wait 3 years and they do the second one, or they need to wait for the others? And also, if they pass the second one, in case they can do it, is it like the transmission assessment survey for lymphatic filariasis, that then it's kind of classified as achieved? And then what happens if it fails? Do they need to do again 5 rounds of MDA, or is it 2 rounds of MDA? Yeah, so that's it. Thank you.
Yes. Do you want me to respond, Anouk? Or do you...
Yes.
Okay.
Please go ahead.
Yeah, thank you, Xavier. Thank you for the question. Yeah. So the first thing is that the validation is for the whole country. It's not for by region. That's first thing. But if different region are at different level, many countries are like that. Even if you have done more than 5 years together, you can do the impact assessment and find that some of the region have achieved the threshold, others are still again behind. There you can adjust the treatment, but you can say that they have achieved the threshold, but the validation will be for the whole country. So you need to have this threshold in the whole country to be able to start the process. So if a region have reached the threshold, there are two things. There are validation, and then there are also the continuity of the preventive chemotherapy, depending on the prevalence that you have. As you have seen in the MNE framework, if a region has less than 2% of any STH prevalence, then they should either halt the PC or do event-based PC. So you can choose to treat children when they enter the primary school and when they go out of the primary school, because the environmental criteria for this disease, we can say that you can stop for a long time unless you're sure that the wash intervention, the wash infrastructure is well done in the country, so that the contamination will not continue. Otherwise, you'll have to do surveillance every time and to be able to see the rebound. If the STH prevalence goes up, then you will have to start the PC. So the validation, it's a process, it's a national process. It's not by region, but to adapt the PC frequency, you can do this by region. I don't know if I have responded to your question.
I think that's good. We have an additional person with a raised hand, Birhan Abtu. I will bring Birhan in, and then we've got a couple of questions in the chat as well. So let's see. Birhan, can you unmute?
Yeah,
Oh,
thanks. Great. Yeah, appreciate for letting me to join this call. And I'm grateful for WHO moving forward on this STH and setting criteria for validation on STH. And I have 3 comments. One is on diagnostic. What are the proposed methods for diagnosis? And then the second one is about implementation unit, how it is defined. For example, in case of Ethiopia, district level is implementation unit, but usually very huge, with a population of 100,000, and 20 to 30 villages, and there is a risk of overlooking localized hotspots within this smaller subunit. So our implementation unit defined. Then the last question is why this validation is important, or while still women in reproductive age group remain under active intervention, because there will be a cross transmission. So these are my questions. Thank you. Over to you.
Yes, thank you, Bjorn. Thank you for the question. So for this, the target that was set for the validation of elimination as a public health in children, we use the CATO-CAT as it has been demonstrated that for this target, CATO-CAT will be able to give us the answer we want. So the diagnostic will be the CATO-CAT, and also you don't forget that this threshold was based on the CATO-CAT, not other diagnostic methods. So we use the CATO-CAT for the impact assessment. The implementation unit is defined by the country, could be the district, could be the region. But when you are doing the STH is different from LF, or mostly it's homogeneous, and it has environmental factors, so that you can still do the survey. You can still sample and have a vision of the region without having to sample everywhere. To use the geostatistical methodology, so that otherwise, if you look on the smallest, you want to collect data there, you will not get any resources to be able to do so. So that's why in the MNE framework, we give country to choose the methodology to use for their survey depending on the resource they have. We don't want to put it to restrict country on doing their impact assessment because they don't have funding, but you can still do it using different methodology. And it has been well noted that using the model-based geostatistical methodology can give you the precision that you want, and with less resources. At the end, you don't have to collect using the information that you have since the baseline, and also other surveys that have been collected in the previous year. So the implementation unit depends on how you have defined how you implement the intervention, but the most important is to be able to show that if it's a district or in that region, the prevalence is less than 2%. It is less than 20%, and the moderate and heavy intensity is less than 2%. So the validation, it's a process. WHO has put this threshold because we have been doing, it's a program that has been there for 20 years or more, and you need to show progress. Without this, we will not show any progress of the program. We don't say that the disease will be finished or we will be eliminating the transmission, because we know that this is not something that, at least for now, we don't have any evidence that it's possible. It has been shown that it's possible in a few settings that have already reached the elimination of morbidity. So the objective of WHO was the elimination of morbidity in children. And that's what we want to show, that we have at least achieved this. Yeah. Thank you.
Thank you very much. That's really helpful, Denise. Thank you. I have a few more questions, but I just want to check on time. How are we doing, Crispin, with the time?
We are still okay, so you can run through the next set of questions.
Great. So there are some questions in the chat and also a question in the Q&A. But just to cover one of the questions, well, two of the questions in the chat was really around this understanding of once the EPHP has been validated, or when you're going for validation for EPHP, how does this impact decisions around preventive chemotherapy, if that is still needed? And also, how does that impact the donated drugs? So if going for validation of EPHP, are you still able to request donated drugs? Do you still need to do MDAs afterwards, or is the idea that you no longer need donated drugs? You no longer need to do MDAs, but you can just focus on surveillance. So perhaps if you could expand a little bit around the incentives for countries to go for validation and how that impacts drug donations and MDAs.
Okay. Yeah, thank you, Anouk. So we have we need to separate things. We need to separate the validation, the EPHP target, and also the PC continuation and the drug donation. So the PHP have set the targets for achieving this is prevalence that is for any SCH less than 20% and MHI less than 2%. So if, for example, a country has a prevalence of any SCH that is around 10%, it's less than 2%. In some area, in those areas, they can decide. It's well stated in the MNE framework. They can decide to stop PC in those areas or to do event-based treatment. And when the prevalence is between 2 and 10%, then they will have to do a PC every other year, so once every 2 years. And when the prevalence is between 10 and 19, then they will have to do once a year. So which means that's why I say that the validation doesn't mean to stop PC. Depending on the prevalence that you have in the country, you will have to adjust the frequency of treatment. This is another thing. The donation drug it was set. What we have now, we have the agreement until 2030 for the donation, and if we then it will go by decreasing, and after 2030 there will be no more donation for albendazole. The GSK have already given this information to WHO that they will no longer give the donation. So for WHO, they will have to prioritize countries that will get the donation based on where they are in achieving the validation. So we hope that countries that have achieved elimination as a public health problem will need less drug because they will have to adjust their treatment, and they will be able to integrate the procurement of this drug in their local drug procurement. That's where country needs to go. So which means that if you have achieved, you will need less drug as a country, and we hope that country will be able to take ownership of the drug procurement for their program, but their program will still need to continue to do PC. Thank you.
Thank you so much. I'm sure that there will probably be a little bit more questions directed to WHO to really get the nuance. As you said, it's really, you got to separate the two. So getting the nuance clear. So by all means, please, participants, do contact WHO for clarity on this. if you want to really understand the nuance for your particular settings and contexts. There is a question here. How does the programmatic decision from current criterion of less than 20% differ from previous criteria of the less than 2%, 2 to 10, less than 20, and over 20%? I think you did explain a little bit about this already, Denise, that you were saying that the decisions around the frequency of PC is different from the criteria for the validation that you need to meet. Is that right?
The PC is based on the prevalence of any STH. So the PC round decision is based on prevalence of any STH. While the PHP criteria has two, has on the intensity and on the prevalence. The intensity, the moderate and heavy intensity prevalence need to be less than 2%, while the prevalence of any STH need to be less than 20%. So that's the PHP. But for for the PC decision, you need to go for prevalence for any STH. And if depending on where you are, then you can adjust the number of rounds of PC that need to be conducted in that particular area.
Thank you. And actually, Hamid Gaji has just said you have answered that very clearly. So that has been answered. Thank you very much, Denise. I think we have one more question in the Q&A, which relates particularly to Malawi. And I don't know if you're able to look at the question, Denise, because I think we might need to move on. But if you could look at the question in the Q&A from Michael Lukanga about the Malawi situation. Perhaps that, if you're able to type in an answer, that would be great. And Alain Clavier has also noted that there is, in his country, a little bit of a difficulty to do with getting treatment to women now that the mass treatment for filariasis has stopped. So those are the two questions in the Q&A. But I will hand over to Crispin and to Cosmas for the next section. Thank you very much, Denise, for answering these questions for us.
Thank you.
Thank you. Over to you, Crispin and Cosmas.
Thank you, thank you, thank you. Thank you, Denise, for that engaging conversation around that. And thank you, Anouk, for taking the questions. Possibly in the interest of time, as we move on, I'll just now, hand this over to Cosmas to introduce our next speaker. Cosmas, the floor is yours.
Thanks very much, Crispin. I'm pleased to introduce our next speaker, Salisu Ahmad. He's the NTD Program Manager at Helen Keller International in Nigeria. Salisu has been instrumental in implementing integrated NTD delivery programs in Nigeria, one of the highest burden countries for both Schisto and STH globally. And his work has focused on how preventive chemotherapy for multiple entities can be delivered together efficiently and what the practical lessons are for program design, drug supply, and community engagement. Today, he will share Nigeria's experience on the compatibility of integrated platforms, what works, what doesn't, and what the NNN community should consider as integrated approaches become more common. Salisu, over to you. Thanks.
Thank you, Cosmos. Good day, everyone, and many thanks to the subgroup for providing this platform for me to provide a perspective on our own perspective on the integration of STH, MDA, and Akwa Ibom State with other companies. Okay, so just by way of introduction, Helen Keller in Nigeria is in 12 states and the capital of Abuja, supporting nutrition and neglected tropical disease programs. And Akwa Ibom is one of those states where the NCAS integration was piloted in 7 of the 31 LDs that are endemic for STH. So the Ministry of Health introduced the NCAS as the National Collaboration Action Strategy to address persistent challenges to vertical program implementation across the health interventions. It is cited in the SWAP office, the sector-wide approach program coordination office. Before the NCAS strategy programs are implemented as vertical programs, such as the NTDs, malaria, polio, and measles campaigns. But in 2026 February, the NCAS integration was piloted in 7 LGs, like I said, in Akwa Ibom State, where it was integrated with measles and rubella campaign. And it seeks to address this, provide strategic solutions in terms of integrated program coordination, resource optimization, digital data integration, and alignment with health reforms. In terms of program coordination, NCAS unifies the vertical programs through joint planning, harmonized timelines, and shared supervision structures. Like the MR program and NTD program came together to sit down and plan the entire campaign as a single approach, which means the State Ministry of Health led the process, whereby the primary healthcare agency, the NTD unit came together with support from partners led by the WHO to make sure this coordination happens. And then in terms of resource optimization at all levels, NCAS reduces redundant activities and it optimizes cash resources that we have in Nigeria. And then thirdly, the digital data integration was also promoted, where data tools provide near real-time field activity data, which enables evidence-based decision at state and local levels throughout the integration. And then an alignment with health reforms. This strategy aligns fully with the reforms at all levels in terms of strengthening accountability, sustainability, and leadership commitment. Now, how it was operationalized in terms of the integration. Because of the difference in the mode of operations, the state has adopted school-based approach to treat STH in all endemic LGS with a few fixed posts to cater for non-enrolled children, while the other campaign, the MR campaign, is purely community-based. So the collaboration was reduced to these 4 aspects of planning, training and supervision, digital data and monitoring, and then capacity building. NTD program and the MR campaign program came together and conducted joint planning for these 7 selected LVAs. And then a single work plan was developed and agreed upon by the stakeholders. Then for training, training at state level, SGA level, and health workers levels were also integrated. Data tools were harmonized, and then also supervision was also integrated, whereby health worker that is used to supervise only MR will now include in his daily work plan to supervise and coordinate STH MD activities, which has teachers as implementers, whereas the MR campaign has the vaccinators. Another thing is digital data monitoring, where the platform enables real-time data collection, progress tracking, and rapid response during the implementation. We have had the situation room where daily data is called in and then reviewed by stakeholders, and then feedback is provided to the field as to where is lagging behind, where target is met and where target is not met, where resources are optimally used or otherwise. The last one is capacity building support. In support from partners, enhanced capacity building, independent monitoring, and on other things. Now, what are the achievements? The key achievements of the integration, the pilot integration, is we have witnessed enhanced collaboration, where joining planning and shared accountability replace siloed decision making. And also we have the optimized resource use, where you have the state and LGA, as well as the health workers working to on the two programs at the same time, providing same functions they provide differently in the previous interventions. So we have the optimized use of resources, and then we have improved community engagement. We've witnessed, as the partner supporting the state on NTD, we have witnessed an opportunity to deliver multiple interventions through coordinated platform to improve community acceptance. And then the last one is data-driven decision-making, where we've seen daily feedback provided to the implementers, to the ward level supervisors, the LGA team, as to where we did well and where the program needs to implement, and which LGA has achieved their target, like I said, and which school has actually submitted data or not. Now, the efficiency gains and impact on community participation. We have witnessed reduced field visits, where, for example, the LGA team members that are working on MR only, or the director of primary health care agents, for example, in an LGA, has to supervise one campaign at a time, or has to visit 2 places at a time. But now, because of the integration, they were able to reduce their field visits, where one visit to an LGA will cover all the programs being implemented at the same time. They'll go to the schools and monitor treatment. They'll go to the LGA and monitor coordination. They also go to the health facilities to monitor other aspects of the implementation, such as the commodities consumption. We have also witnessed optimized human resources, where supervisors, mobilizers, and data teams manage multiple objectives in single engagement, which has boosted human resources. Now, the next one is enhanced accountability. Due to the integration, NTD was able to benefit from enhanced accountability, whereby every day the data will show number of children that have been dewormed and the number of medicines that have been used vis-a-vis the number of schools treated. And then that will give a sense of accountability as to how many tablets have been used, how many things have finished, and so also the other part of the campaign, which is the measles and rubella implementation. Then we have also witnessed resource allocation benefits, as it's created fiscal space for quality improvement, and also expanded coverage and digital infrastructure investment. There is this platform where the ward focal persons transmit activity data every day. And that has given the opportunity, like I said, for the program coordinators at all levels to make sure program is expanded to reach all the target areas. Now, community participation. In terms of community participation, we have seen fewer and well-coordinated visits, which has reduced disruption and enhanced trust in health interventions among community members. We've seen the community members talking to the teams as one, the MR team and the teachers at the same time, implementing the same interventions at the same time, which has reduced community visits. Children that have been vaccinated in school will also be dewormed in school. So we don't have a case of where this was not, this has been vaccinated and this was not dewormed or what have you. Then unified health messages. Through integration of health messages, the community sensitization and mobilization messages were unified, and also that has clarified health behaviors and strengthened community understanding and acceptance. Now, the key limitations and constraints, like I said, it's a pilot integration in 7 out of 31 LGAs that are endemic in the state. Yes, we have witnessed increased workload to especially the teachers that are responsible for deworming, Teachers are supposed to work 8 a.m. to 2 p.m., but then because of the integration, sometimes they stay beyond that time. So also the MR team that are had have fixed course now have to work with the teachers in the fixed course in the school rather than the usual places they work, because the team is that any team that is close to school is actually cited in the school so that they will be able to integrate. Again, the next constraint, the limitation is capacity variability across the LGAs. We've seen differences in the capacity to deliver in terms of the use of the data tools and digital reporting tools that we have. The next one is the operational coordination constraints. Coordination was hindered by inconsistent commodity availability to program priorities. The intention of the integration was to include malaria, but then there were no commodities at that time, so it was limited to MR and the STH deworming campaign. So the coordination was hindered by inconsistent commodity availability, especially in terms of there were few reports about data tools from some of the LGAs during the daily calling data that we have jointly conducted led by the WHO and other partners. Another limitation was the connectivity and digital literacy issues, which limits and varying digital literacy level hinder real-time remote areas. So because not every LGA, not every community has access to mobile network. Some of the schools, some of the wards, some of the places, communities were not able to transmit their data real time. So when it comes to the daily call-in data, those LGAs, those wards, those schools have to be treated separately as of the time they have connectivity to the network. And then the last one is the unavailability of malaria intervention at that time to make the integration three-dimensional. Now, our recommendation is optimize workload arrows for the stakeholders to prioritize workload optimization and clear roles to prevent fatigue among frontline implementers. Then capacity building and supervision to institutionalize continuous capacity building and supportive supervision to reduce quality disparity across the LGS and the wards. Then program harmonization, harmonize program timelines and logistics early, minimize coordination bottlenecks. Final one is to invest in digital infrastructure through offline capability digital tools and user training to strengthen data quality and timelines. So these are the actions we have recommended as partners supporting Akwa Ibom State in terms of NTD implementation for future integration. So thank you very much, and I wait any questions.
Thank you very much, Salisu. I think Nigeria's experience is really instructive for us to really reflect again on how best to integrate our primary healthcare activities alongside entities at a larger scale. We will now open the floor for Q&A. We have 15 minutes for this, so if you want to raise your hand or drop a question in the chat, please do so, and Anouk will help us read it out.
Thanks, Cosmos. I see we already have a question in the chat, and this really, the question is, what impact does NCAS have on routine service delivery? Did you do some assessments to understand the impact? How frequent is NCAS conducted in a specified local government? And what are the key challenges to implementing NCAS across settings with different priorities? So really, there's some questions there perhaps that you could expand a little bit on Ahmad, Salisu, that would be great.
Okay, thank you very much. Like I said in the beginning, the NCAS integration is still in pilot stage in Nigeria, and Helen Keller is the third partner to support such integration. 3 more states have conducted MDAs in integration with other interventions, and as partners, we have already shared our insight with the NGO coalition in Nigeria to put together learnings from the integration so that we can speak with one voice. So the NCAS, like I said, is still in a pilot stage, and we have not even gotten to the level of full-scale integration in any of the states. So until we have the full-scale integration in the states, then we will think of streamlining down to the routine health system. I don't know if this helps.
Thank you. Oh, sorry, Cosmos.
Please do. Yeah.
No, I was just going to say thank you. That's really helpful. We have one person who has raised their hand. So I'm going to see Lenson Kariuki. I'm going to allow you to talk. Okay, Lenson Kariuki, can you unmute yourself?
Yes, thank you. So my question was around domestic resource mobilization. I would like to ask whether, as much as you are, embedding NTDs into the health systems, have you been able to explore the best approaches for domestic resource mobilization for sustainability, going forward? Because I know this is donor funded, and most programs are donor funded. As much as we are integrating, we need also to look at the aspects of domestic resource mobilization. Were you able to explore this aspect? Thank you.
Yes, thank you very much. Resource mobilization, local resource mobilization is always on the table of the national program. I'm very sure I've heard many times when the national coordinator at the Federal Ministry of Health talk about the effort of the Federal Ministry in terms of local resource mobilization. But let me speak for Helen Keller that I work for. For us in Helen Keller, we've been working with local partners in the state of Akwa Ibom and other states that we work. For example, the Akwa Ibom we are talking about has been supporting their own NTD, World NTD Day celebration every year, plus conduct of hydrosis surgeries anytime donor resources are being utilized to hold the camps. You see 5, 10 surgeries conducted by the state, all in the effort to promote local ownership. Thank you. For the whole country, it's not for me to talk about. The national program on the right platform, I'll speak to that. Thank you.
Thank you very much. Cosmos, do we have time for one more question, or do we need to move on?
I think we can take one more, then we move on.
Excellent. We have one question from Michael Luhanga. What was your experience on data reporting tools? So was this also integrated? How did you handle the data reporting? Over to you, Salisu.
Yeah, so data reporting was handled differently at implementation level, but at ward level, you have the ward focal person. Ward is the smallest unit of administration in Nigeria, so you have the ward focal person collecting data from the MR team and data from the NTD teachers that are treated in the schools. And he put on the same template and transmit real time to the LGA level, where there's a unified template that is being used to enter the data. So we have had the same dashboard for calling data every day, containing data from both implementation of MR and also the NTD. And that's what informed the feedback the program provided to implementers at all levels on where we have done well and where we need to improve on a daily basis. Thank you.
Excellent. I think that should be it with our Q&A. Thanks very much, Salisu, and to everyone who has contributed to these discussions. I will now hand over to Crispin for our governance update. The floor is yours, Crispin.
Thank you, Cosmos, and thanks again to Salisu for sharing the Nigerian valuable experience. A good lesson to the team. I know a very topical discussion currently in terms of integration. So really looking forward to see how we move those particular pieces moving forward. I would now just like to move on to an important governance moment in terms of the disease-specific group, just sharing updates with the group. Over the past year, we have undertaken a government refresh aimed at strengthening representation, broadening participation, and positioning the group for the next phase of its work. This process has included reviewing our membership, updating our terms of reference, and conducting nominations for the vice chair and an advisory council. So I'm delighted to share both processes have now been complete, and I'm pleased to formally announce that Dr. Joseph Kumbu of CBM Nigeria has been elected as the vice chair of the NNN SCH STH DSG Specific Group. Joseph currently serves as the NTD technical specialist and a senior management team at CBM Nigeria, and really brings extensive experience to the NTD programming, program implementation, stakeholder engagement, as well as strategic leadership. And as a vice chair, Joseph will support the chair jointly to represent our DSG within the broader NNN governance structure, including engagement with the NNN Executive Council. The strength of the support he received during the election reflects the confidence of our membership as in his leadership and his contribution. So Joseph, congratulations once again, and I would like to invite you to briefly introduce yourself to the group. Over to you, Joseph.
Thank you, Mr. Crispin. Good morning, good evening, good afternoon for everyone. As Crispin has mentioned, my name is Dr. Joseph Kumbu, and I work with CBM, Christopher Blending Mission, as NTD Technical Specialist, and I'm based in Nigeria Country Office. CBM is an international development organization which is committed to improving the quality of lives of persons with disabilities in the poorest communities of the world, including through NTD's programming. I bring to this role a background of NTD's programming through public health, field implementation, and research. I'm particularly interested in how we can strengthen the connection between NTD's programming and disability inclusion. I look forward to supporting Crispin and the steering committee, engaging with our advisory council, and contributing to strategic priorities of this group. I'm here to serve the membership, and I welcome you. I welcome your input and ideas. We are at a very difficult stage in our implementation where funding is dwindling, and then we are also hearing that even the drug donation is actually going to cease in the coming years. It is time to actually step up advocacy for domestic resource mobilization. We walk through this journey together to see how best we can address these challenges. Thank you very much. Over to you, Crispin.
Thank you, Joseph, and a round of applause for Joseph. Congrats again in joining the group. Really looking forward to working with you. I'm also, equally pleased to introduce our newly established advisory council. Nook, you could share that. The purpose of the council is just to provide strategic, guidance and broaden stakeholder perspectives, strengthen links between our disease-specific group and the wider SCH STH ecosystem. The council brings together expertise from ministries of health, NGOs, advocacy partners, technical experts, and affected communities, as well as WHO observers. Members will engage on a quarterly basis, contributing to priority setting and agenda development, and help also to strengthen connection with government, partners, WHOs, and the communities that we continue serving. We are fortunate to have an incredible, diverse, and experienced inaugural council, including representatives from Senegal, South Sudan, Tanzania, Nigeria, the Mentor Initiative, Global Schistosomiasis Alliance, and other partners. So please help me in welcoming the Advisory Council members, Momadou Sam, Dr. Abu Peter, Dr. Ahmed Mugaji, Mohamed Nyati, Xavier Badia, and continuously Mariana and Anouk. So we look forward to really learning and working alongside you over the coming 2 years of supporting the group. So just moving to the tail end of this, really appreciating colleagues, if we are approaching the end of today's meeting, just like to take a moment to reflect on what this session has provided us. A very productive session today, hearing updates from WHO on the future of STH validation and what countries need to consider as we move towards elimination as a public health problem. Practical lessons from Nigeria on integrated delivery. I know this is happening across, diverse settings. It would be very interesting to kind of see a consolidated, platform where some of those things would be shared. And, finally strengthening our governance by welcoming our vice chair. Very excited to have Joseph joining us. These developments basically position our DSG for the next phase of its work. And I would really also extend my sincere, appreciation and thanks to Dr. Denise and then Dr. Salisu for generously sharing their expertise and experiences with us. But before I close, I would just like to, have a few additional updates. One is the conference, the NNN annual conference, the upcoming NNN annual conference will be taking place in Rwanda. Previously, I know we had planned Abu Dhabi, but that would possibly moving on to the new year. And so this year's conference will also continue to provide an opportunity for the SCH STH community to reconnect in person, basically share experiences, explore innovations, and discuss the future direction of our program. Our DSG is will have a dedicated session during the conference, and further details will be shared soon on that. So that basically brings us to the tail end of this, and on behalf of the steering committee and our newly elected vice chair, Dr. Joseph, thank you once again for joining us today. I know the meeting notes will follow up in the coming days as soon as we can. And we really look forward to continuing these conversations. I know it is not necessarily complete at this particular time. I know there are a lot of questions that are still unanswered and a lot of areas that would require some clarity. So I know it's a continuous conversation that we will continue to have. So really looking forward to have these continuous discussions and conversations moving forward as we work together to accelerate, the progress towards elimination of schistosomiasis and cell-transmitted Helminths. So I just want to, wish you a wonderful rest of the day if you're starting your day, and if you are ending the day towards the end of the week. I really hope that you'll have a wonderful remainder of the day. So thank you all. The meeting is adjourned, so feel free to leave. Thank you.
Thank you, everybody. Fantastic.
Thank you.
I will close the webinar in a bit, but also thank you for the interpreters. Did a great job, and thanks to the team. I see all the attendees are dropping off slowly, and we can close and debrief next week. Thanks so much.
Thank you.
Thanks, everybody.
Thank you, everybody.
Thank you.
Have a good day.
Talk to you soon. All right, bye.
Bye-bye.